And no problem. Jayant, if you want to start, you can start. Yeah.
Yeah.
Should I start or what?
Sure, sure.
So good morning, everyone. And on behalf of RO, our organization, I would like to welcome you all for the wonderful webinar. Congratulations, Purvi and Neeta, for initiating this program for our people. And we have this webinar, the first webinar of the RO is on in this season is by none other than our patron and the person who's being known in the country for his work in metabolism, nutrition, special emphasis on nutrition, and who's going to be there for discussing about the classification of obesity and its clinical implication. Sir is Dr. Anup Mishra. Sir is a very senior diabetologist from the city of Delhi. He was the ex-head of Department of All India Institute of Medical Sciences, and he is being awarded the highest honor of the country, Padma Shri, in a long back, almost 2007, if I'm not wrong, or near that. So, sir, and he's also the recipient of BC Roy Award. Just previous to the year of his Padma Shri, he got Dr. BC Roy Award also. So, with lot many, almost more than 230 publications or 270 publications, or 370 publications, Jayant was just sharing to his credit. And all high-end journal. He's also the chief editor of the journal, which has got a very high impact factor, and which is diabetes of the metabolism, and that particular journal has become very a popular journal of Diabetes India across the globe. So it is all this credit goes to none other than Dr. Anup Mishra, and who always guides us for anything in the field of diabetology across. So a person who's a mentor, the guide, the teacher of teachers, and it's very difficult to get him across on such forums. So RO is really thankful to you, sir, for joining us for this particular day. And this is the first program of RO on these lines. And we have our president, Dr. Mahendra Narwaria, who has also joined here from the city of Ahmedabad. And we all welcome you all for this meeting. Over to you, sir, to speak on.
I'm just adding two lines
Yeah.
about sir, and this evening is special because Arrow is with the Doyens, and we have our president already joined us, and we have Anup Shah and Nita ma'am, the faculties, and just a formal addition to the Padma Shri Anup Mishra Shivi. He is the executive chairman of the Fortis CDOC Hospital for Diabetes and Allied Sciences and the director of the National Diabetes, Obesity and the Cholesterol Foundation, which many of the metabolic physicians have not dreamt till now. He is the president of the Diabetes Foundation of India and the former professor medicine of All India Institute of Medical Science, New Delhi, and the former faculty of the Human Nutrition and Endocrinology and the UT Southwestern Medical Center at Dallas, Texas, USA. His major achievements are more than 371 published research papers analyzed by the Stanford University to be among top 2%, which all of us are proud of. He is scientist in diabetes from India, ranked globally, established definition of obesity for Indian population. The classification that you'll be listening from Professor Anup Mishra is his own work, and hardly we get a chance to listen from the horse mouth. The citations are 49,000 to 426. The H index is 111 and the I-10 index is 495. This tells that why he is among top 2% scientists in the diabetes from India ranked globally. The editor-in-chief of the Diabetes and the Metabolic Syndrome, the Clinical Research and the Reviews from Elsevier. He is the associate editor of the Journal of the Diabetes from the USA, member of the Academic Board of British Medical Journal, member of BMS Regional Advisory Board for South Asia, member of BMJ Commission on Academic Medicine, member of the Lancet Commission on Obesity 23-24, invited member of the Research Honor Society Sigma 11 in the USA. And the awards include Padma Shri, already told by Dr. Shunil, in the 2007, and the BC Roy Awardee 2006. He is the author of the book Diabetes with Delight in English and Hindi. So this CB is a dream for every metabolic physician. He is a mentor. He is a guru to all of us. Over to Shar for the today's night webinar, where you are speaking on classification of obesity, and I'm sure this will be a path showing to all our junior people who are interested in obesity, and AARO is proud to host you this evening. Over to you, sir.
Thank you, Jayant, and I must thank Purvi, Sunil, Dr. Narvaria, and my colleague Nita, who will be speaking subsequently. I thank you for giving me this opportunity on this wonderful platform that I'm going to speak on. Just give me a minute, I'll share my slides. Just hold on. So can you see my slide?
Yes, sir.
Okay.
It has come.
So I'll take 25 minutes or so to project what is the current knowledge on the diagnostic criteria of obesity in Indian population. But that's not only for India. It's the whole world is looking at obesity from a different point of view. Uh, and that's because it is rising everywhere and also in India. I'll show you some data. And also, with the advent of new obesity drugs, there is a rekindling of interest in obesity in every country of the world. This is my research team. These are some of my disclosures. I'll be discussing only a few studies because of shortage of time. I begin with a quote from my favorite author, and he tapped my forehead right where his damn whistle had bumped me. That's where everybody's fat. You put what's between your ears on diet and you're going to lose weight. Stephen King. That's a little simplistic, but still something to start with, something good to start with, diet and exercise, and that remains the cornerstone of treatment of obesity. Now, here are some temporal changes in the prevalence of BMI categories in India from 1999 to 2021. And this is a recently published paper. You can see, and good part is that the severely thin have decreased over a period of time, if you see this. And but the bad part is that the overweight and obese have increased over a period of time. This is there in women as well as men both. So clearly establishing that the obesity is increasing in Indian population, and it is something to reckon with. 20 years back, when I was talking to the health minister of India about obesity, he won't listen to me. He won't listen to me. You would say underweight is the problem, anemia is the problem, maternal malnutrition is the problem, obesity is not. So something which has changed over a period of time. Now, this is the current world situation. This is changes in the top 5 countries with the highest burden of common metabolic diseases from 1990 to 2021. And this is our very good publication on global burden of metabolic diseases in metabolism, which is already cited almost 50 times in the last 6 months. Now look at the ranking of India as far as various diseases are concerned. Type 2 diabetes, hypertension, obesity right in the middle of it, high total cholesterol, and fatty liver. and where it was in 1990 and where it is now. So obesity, we are at number 2 in terms of dailies, and we are number 1 in as far as diabetes is concerned. We are also number 1 in fatty liver. These are data which is not to be proud of, and these are data we should be acted upon in the policy and principles and by all of us to tackle this epidemic which is going on. Now, this is the again number of deaths uh, attributable to high BMI in India. This is the same publication, Global Burden of Metabolic Diseases, from 1990 to 2021, and you can see that deaths attributable to high BMI in both genders and in males and females is all increasing from 1990 to 2021. So it is not only increasing other metabolic diseases, but also increasing mortality, which is a matter of great concern. Now, just a little bit of preamble for those people who uh, are looking at obesity as a career option, those who are young. I'm sure many of the people who are present here, they already know about some of the slides that I'm going to project. Just a little bit of Indian body phenotype, and their main thing is primacy of abdominal adiposity. Now, if you look at these data, this is a 21-year-old paper cited almost more than 500 times, written with Dr. Naval Vikram at All India Institute of Medical Sciences. At that time, he was my junior in AMS, where we compile data of BMI in the rural Indians, urban slums, urban Indians, migrants, Chinese, Mexican Americans, Caucasians, and African Americans. And as you can see, that the BMI of our average Indian population is not much less than Mexican Americans, Caucasians, and African Americans. But if you look at the body fat, we have a lot more body fat. And if you compare just the migrant Asian Indian with African American, look at that. Their average BMI is 27 or 28, and their body fat is also 28. Our average BMI is 24 or something, and body fat is 33%. So there's a grave mismatch between the BMI and body fat that doesn't bode well as far as our metabolism is concerned. But this also means that the onset of diabetes is at lower BMI. Now, here are comparative data between the South Asians, Chinese, blacks, and whites, and incidence of diabetes per 100,000 population. It occurs in South Asian at 24 BMI, Chinese 25, black 26, and white 30 BMI. So there's a huge difference between South Asians and whites as far as the occurrence of diabetes is concerned. And that itself, this particular itself, and we have done some studies, and a number of other people have done some studies and have reached similar conclusion. And these were the data that compelled us to revise definition of obesity based on BMI in 2009. I'll come to that in a minute. Now, having seen this slide, let's go to the abdominal adiposity. This is one slide taken from one of our studies. We have done multiple studies in the last 2 decades as far as the body fat depots are concerned. And our prime interest is in abdominal fat and hepatic fat and pancreatic fat. And if you look at here, most of you would be knowing what this is. This is the single slice MRI at lumbar vertebra 3-4 level, showing the white area, that fat, and the intra-abdominal fat is quite a bit surrounding the organs. And here is the subcutaneous fat, and it is divided by this fascia. If you see this fascia, into deep subcutaneous fat and superficial subcutaneous fat. Deep subcutaneous fat is mostly found in the posterior areas, at lumbar vertebra 3, 4, 5, 6, 3, 4, 5, S1, around that. So this is very, very thick, the deep subcutaneous fat. I'll come to that, what is the sequence of deep subcutaneous fat. But suffice to say at this point of time that this deep subcutaneous fat is anatomically different from the superficial subcutaneous fat, and it has got a larger adipocyte, more metabolically active. So Indian population has more of both type of fat, subcutaneous as well as intra-abdominal. Now, here is a marketplace in South Delhi, and I'll show you two people, but seemingly they are non-obese people. This guy and this guy. And if you look at this guy, this office worker cycles 5 kilometers daily, BMI of 19.5 at a lower limit, waist circumference entirely normal, likely that he will not develop diabetes, type 2 diabetes in the future. And if you look at this guy, again, it is not too bad. It doesn't look too bad. But BMI is upper limit of norm. So it's still within the limit that was set by us subsequently. Waist circumference is high, more than 90 centimeter. Now let's go and look at this guy's uh, the single slice MRI. And if you look at the fat, is still, he doesn't look too fat, but the subcutaneous and intra-abdominal fat is far too high. And if you look at the insulin levels is already high, and the fat depots are high, triglyceride is high, HDL is low. And if we go on to another guy, where the waist circumference is same, BMI is same, but the subcutaneous fat is increased. If you look at the previous one, this one, and it is further increased, subcutaneous fat. Here, the subcutaneous fat is 137 and intra-abdominal fat is 142. This is centimeter square. And if you look at the other one, 147 and 146. So subcutaneous fat is now increasing in various other people. Look at the subcutaneous fat, but not the intra-abdominal fat is not increasing so much. And at the same time, the metabolic parameters are getting abnormal. Now here, previous one, the fasting blood sugar is normal. Insulin was 104. Here, insulin has increased, fasting blood sugar has increased, is in pre-diabetes category. And still, waist circumference remains the same. So there is a lot of heterogeneity in the abdominal fat depots at the same waist circumference level. And if you look at the fat here, it is thicker. Now, coming to what is contained in this kind of subcutaneous fat, this is our colleague from the Dallas who did this very good study and published in 2013. They compared Asian Indian population with whites. They took the subcutaneous fat sample and looked at the inflammatory genes. Now, if you look on the left side, their BMI is comparable, body fat is comparable, waist circumference is comparable. But if we look at the subcutaneous fat here, these inflammatory genes are all much higher, twice or thrice in Asian Indians versus white. Now, if you look at the fat here, taken from some of the examples which I have shown you, adipocytes in the subcutaneous fat is larger, more insulin resistant, and if you look at the in between the fat cells are a lot of inflammation. So fat and inflammation are packed together. These are insulin resistant adipocytes, and they are overall can be called as sick fat cells. Not only that, the liver triglyceride is higher in Indian population as shown by this particular study, which is a comparative data between Asian Indians and white Caucasians. And if you look at and they were matched for BMI, they are matched for body fat, everything matched, and they're actually non-diabetic and non-obese. But if you look at the insulin resistance, Indian population was much more insulin resistant, and the liver fat was 2.6 times more. So, non-obese, non-diabetic Asian Indians pack a lot of liver fat, and that has potential for disrupting metabolism. Now, this is our recent article, which is in press, where we put together a diagram. This diagram can be easily understood. If you have excess energy intake and sedentary lifestyle, you develop obesity, but predominantly abdominal adiposity, uh, intra-abdominal fat increase, superficial subcutaneous fat, which I showed you, also increase. But it is the deep subcutaneous fat which stores more triglyceride. However, at some point of time, while expanding, it stops expanding and then throws out all the fat outside, increase in the free fatty acid. So those who say that only intra-abdominal fat is important for Indian population, no, that is incorrect. It is the intra-abdominal fat plus subcutaneous and particularly deep subcutaneous fat which throws out the free fatty acid, which gets deposited in the liver with disastrous consequences, and then subsequently they deposited in the pancreatic region with increased pancreatic fat, which leads to decrease in the insulin secretion, insulin response, and type 2 diabetes. So this is the pathway for NFLD, for fatty pancreas, for dyslipidemia, and for type 2 diabetes in Indian population. Now, this is has been those any of you who are interested. We published a series in the Lancet, Type 2 Diabetes in South Asia, and anybody who's interested can find the details in these three articles of the series. Based on all this, this is the common minimal point as far as body composition of Indian population is concerned, and also phenotype. So we have lower BMI than Caucasians, higher abdominal adiposity, subcutaneous and visceral both, higher liver fat, higher magnitude of insulin resistance and lower beta cell secretory capacity, higher inflammatory markers I showed you, and this overall thinking has developed more over last 2 decades. After 2009, 2009, we were conventional as far as diagnosis of obesity is concerned, and we based our understanding on the BMI and waist circumference, mostly BMI. So that was too simplistic a thinking. And then once we knew about all these things and more research has gone in 2004, 24, 25, we took abdominal adiposity as a major point, and inflammation, insulin resistance, also looked at the various other conditions associated with obesity, including mechanical and metabolic, and then considered the definition. So revision of definition of obesity, nuts and bolts, but before that, what we made in 2009 was a landmark paper. We refined new cutoff for overweight and obesity in Indian population as compared to WHO. We lowered the BMI and waist circumference cutoff, and that was not only adapted all over India but also in UK and USA. So these were the, I'm not going to details of these, but 23 was the cutoff for overweight, 25 obese, 90 centimeter and 80 centimeter, our cutoff for waist circumference. The subsequent questions was whether BMI is a good indicator for obesity. And we rethought about it, we researched about it, and a simple example is a WWF wrestler like the Dwayne Johnson here, whose BMI is 33.5, but he has more muscle than fat. His body fat is much lower than the muscle mass. But if you define obesity based on BMI, then he would be obese. which is incorrect. BMI also does not truly reflect cardiovascular disease and other metrics, and in such cases, abdominal adiposity may be more useful. And this is our publication way back 25 years back. Now, we should use some other measure, BMI plus other measures of obesity or abdominal adiposity. So, would it be okay to measure waist circumference or waist to hip circumference ratio or waist circumference to height ratio? Now, these are the three circumstances which denote abdominal adiposity. Now, each one have its own fallacy. For example, let's look at the waist circumference. That needs training. And a person who's only trained can actually accurately measure a waist circumference. Now, for example, we published some papers quite some time back where we looked at the waist circumference measurement by site, posture, respiratory phase, meal time, and found that it differs if we look at the straight posture versus little bent posture, empty stomach versus full stomach, and things like that. 13 ways we measured, and we found that the difference in measurement is from 1 centimeter to 5 centimeters. So that will change the diagnosis of abdominal adiposity. So our training is required as far as waist circumference is concerned. Is waist hip ratio a reliable marker of abdominal adiposity? Well, when I was a student, I thought it was, but it is not. Now, if you look at the one example, here is a person whose waist initially was 80 centimeter, hip was 100 centimeter, waist hip ratio was 0.80. And subsequently, 20 years later, waist circumference is increased by 20 centimeter, hip 25 centimeter, waist hip ratio remains the same. So it is the flawed marker because both the variables are changing. It is only one variable which should change, the other variable should remain constant. So it should be thrown out of the window. But then another marker has come in, and that is waist height ratio. We published paper with Naval here and found that waist height ratio has a fair chance of predicting cardiometabolic risk. And here, clearly, waist is changing, height is not changing. So it is a good marker, and it should be taken in consideration now. Once you are measuring waist circumference, then also calculate waist to height ratio. So we revised the definition of obesity. Again, I quote from Stephen King, another book. I am overweight, I can tell that, but there are all kinds of overweight people in the world, aren't there? And the important thing is, I'm trying to be better, and that's what we should all try. There are a number of other classification of obesity. One is Edmonton obesity staging. It is a complicated way of classifying 0, 1, 2, 3, and each one has 4 components: metabolic, mechanical, mental, milieu, very detailed, but very difficult to do. For example, a person who's sitting in a village in Haryana will not be able to calculate how to go about classifying obesity based on this staging system. So what we need is simple definition, widely applicable in all settings, reproducible, based on generally reliable evidence, based on general consensus, and should be ethnic specific. And that's where Lancet Commission, which is consisted of 57 members, and I was one of the members from South Asia, started deliberating on new definition of obesity in 2003, and then subsequently about 70 meetings later, the definition was published in January 2025. The concept was simple, and which we have already talked about. Do we rely solely on BMI to define obesity? No, we have already told you about it. Consider adding other measures of obesity to BMI? Yes, waist circumference or waist circumference to height ratio. Now, consider adding functional and mechanical symptoms, for example, shortness of breath, knee pain, hip pain, and things like that, which may occur due to obesity. Yes, we should. and consider adding comorbid diseases, organ dysfunction, yes. Then if we do all this, this is the true definition of obesity where we should act. So Lancet Obesity Commission, they if abnormal fat mass is there, if not there, no obesity. If there, it's obesity. Clinical obese, then there are. It is bifurcated into two: preclinical obesity and clinical obesity. It depend. The clinical obesity will depend on all those factors which I told you about. And at the same time, we released definition of obesity for Indian population. Very, very simple. Very simple. That's what it should be, because that's what is needed for frontline general practitioner who can calculate obesity using a weighing scale, using a waist circumference tape, and asking a couple of questions to the patient. So stage 1 obesity is relatively innocuous obesity. BMI 23, more than 23 is the gateway to both type of obesity. So anything above 23 is abnormal. Then you further stage into stage 1, where abdominal adiposity is not present, no symptoms suggestive of limitation of day-to-day activity, or no obesity-related comorbid diseases are present. On the other side, what we are more interested in stage 2 obesity, where either you take waist circumference or waist height ratio along with it, it should be present, and then one of these two, either obesity associated limitation day-to-day activity or obesity associated comorbid disease. It's very simple to do. All of you should do it, and then decide whether which way, as far as treatment is concerned, we should go, whether we should just rely on lifestyle modification or lifestyle modification, weight loss inducing drugs, injectable surgery, etc. in stage 2 obesity. So my journey of obesity started in 1997. This is my last slide, where we published the importance of subcutaneous adiposity in a very high impact journal, and that was my proud achievement in 1997 when I was in the United States. And then subsequently, 2009 was a path-breaking paper where we redefined obesity. So almost 10 years later. And then there is a hiatus of almost 16 years when the Lancet published the new definition of obesity, and I was fortunate to be part of it. And then we published at the same time, just one day later, we published the revised definition of obesity in Asian Indians living in India. So this is a 28 years long journey. And in between, there are numerous papers which we published. Well, I'm fortunate to be known in the world for this kind of research, and we hope to continue the research. But I think large part of my journey as far as obesity is concerned is complete. So I summarize this particular lecture, and summary is only 2 lines. We present new concept of definition of obesity, and accordingly, physicians can treat it rationally and appropriately using the new criteria. So I thank you again, sir. Dr. Panda, Purvi Chawla, Sunil, Manoj here, Dr. Narwaria, Dr. Makkar, and Nita for giving me this opportunity to present these data here. Thank you.
Great presentation, sir.
Sir, we
Outside
don't
of a long
even,
28
we are
years journey.
privileged to listen to you. No. We
Yeah.
are humble to
This
listen to
is
you.
a long 28 years journey, and you are told not only the change definition, the classification, as well as the measure also you have touched upon, which Nita ma'am will carry it forward, and so much of original work in 1997 when nobody thought that obesity will be so important to intervene, and obesity will be decided as a mother of all metabolic diseases. Then you have worked and published the first paper in non-diabetic population, taking the anterior and posterior subcutaneous tissue, and to aid the YY paradox and the obesity type in the Asian Indians, where we tell thin fat Indians. The classical studies describe more about the problem, and now in the globe, you are the one of the highest contributor in this subject, when we have injectables, when we have surgery, and when we have a lot of approach to intervene. So I thank Dr. Anup Shar, and will be taking the questions in the panel. And also, I invite questions from all our listeners in the chat box, which will be including. With this, we can move on to the next presentation by Dr. Nita Deshpande regarding the measure of obesity, BMI, and beyond. And we know in the last JPF conference, listening to the Sabu Narwaria criteria for measurement, that BMI has become past, BMI has become history, and we have to go beyond for the exact measure, exact stratification, and intervention of these people. I request Dr. Sunil Gupta, my co-chair, to introduce Nita ma'am and topic, and start the second topic of the webinar.
Jain, but just a minute. Wonderful talk by Dr. Anup Mishra. I will just request the AARO board, including Purvi and everyone, that we should have this recorded version also on our website, and few more days people can listen his talk, and we all are privileged to have him here. And to have an online talk, the one of the biggest advantage is that hundreds, no, thousands of the doctors can listen today, and then again they will able to listen it multiple times whenever they want more. So we all are very, very thankful, sir, to you for accepting our invitation and giving a talk on the platform.
Thank you, Banshi. You've always encouraged us, and I thank you from the bottom of my heart for all these years of support and encouragement.
No,
Thank
sir,
you.
but it was real wonderful. We really enjoyed it. Really. Yes, over to now, Sunil, for introduction.
Thank you, sir.
Thank you very much, Dr. Anup Mishra. Thank you, Bansi Bhai, for your comment, and we'll certainly see to it that how best we can we will keep certainly on our website all these recordings, and Purvi, I don't think there will be any problem keeping such recordings on the website. With this, we now invite Dr. Nita Deshpande, who's a part of RO since multiple years. She's a diabetologist and a bariatrics physician from the city of Belgaum, and she's also the associate professor of medicine in the USMK Lee College, and she has multiple presentations on obesity. The moment obesity symposia or some panel discussion comes across the country, she will be certainly there across in as one of the panelists or a speaker in the group. And has multiple publications. She is the past chair of Karnataka RSSDI, principal investigator for several clinical trials. She had delivered KR RSSD Karnataka RSSDI oration 2016, RSSDI fellowship in 2016, FRCP Edinburgh 2016, Vandana Bombay-wala oration, national oration of Arocon Obesity India, and Dr. Sam GP oration in 2021. She is the coordinator for the consensus group of RSSDI clinical practice guidelines in 2022, and also into the task force group of obesity in Diabetes India. So Nita is going to speak on the measuring BMI and beyond. I feel this is something which has already been introduced by Anup Mishra as well as Jayanta a few minutes ago. So I won't go into detail of it, but Nita, over to you, and then we'll have some question answer session for Nita too. Thank you very much.
Thank you. Thank you so much, Sunil. And it is lovely to be here on the first webinar of AARO, something that is close to all our hearts, all of us present over here. And we really should be taking this forward in a big way. It's a great platform. Thank you so much. Secondly, it's a real tough act to follow after Dr. Anup Mishra, but I'm still going to try my best. And let me start by sharing my slides. Uh, one moment.
Small town confidence always there.
Thank you, Manoj. That is so encouraging. Yeah. So here we are, and the topic that I'm going to be touching upon is BMI and beyond. We've all heard very eloquently from Dr. Anup Mishra how BMI can be erroneous, and that's why we need to look at other measures of obesity, which will give us better perspectives in terms of risk and risk management and obesity management in general. So I do not have any disclosures for this talk. So if you look at the value of BMI, uh, does it have any value at all? Yes. It is very good for population tracking. If you look at this, this is US data, but we can see here that it's invaluable when it comes to population trends. And you can see this pattern that it has started going up from 1975 onwards, almost like an epidemic. And this is because of the rapid widespread factors like changes in food supply, etc., rather than genetic shifts. So, as you can very well see here, if you look at it as a population surveillance tool, BMI does continue to provide essential data for public health monitoring and policy development. But we need to understand the limitations of body mass index in any given situation. Though it has been a cornerstone in tracking obesity, now we know that that's not the complete story. We know that when it comes to health, risks for metabolic diseases, for mortality, we have to go far beyond that. We may need to go to body composition and so many other things. And that brings us to the point of what those limitations are. Once we understand this, then we need to go beyond BMI. So you can see here that the BMI is currently defined solely by, obesity by body mass index. And this is European data, but you can see here that, of course, you can always substitute this with, South Asian criteria. But this is just to prove a point that it is useful for identifying individuals at increased risk of health consequences, no doubt. But look at the minuses. It is not a direct measure of fat. It does not establish the distribution of fat around the body, and it cannot determine when that excess body fat that is there is a health problem. So you don't get all of these. And that is why George Bray, who's supposed to be a big name in obesity, made this wonderful table where he talks about the uses and limitations of BMI by literally giving it a scoring. So if you see the zeros, this is where BMI fails completely. That is phenotyping obesity, pathophysiology of obesity, and estimation of distribution of fat. BMI does nothing for that. When you have 2 stars, it is some use in genetic studies and very little use in estimation of body fat. That is by extension, you can apply a formula and estimate body fat, but not directly. But when it only comes to tracking of population weight and estimation of body weight, yes, BMI scores wonderfully well because it's easy, everyone is used to it, and that has been ingrained in us from time immemorial that this is the BMI and this is obesity. But when you look at all these other things, where it's either score 0 or only 2 stars, these are all the areas which are required for us to treat obesity and categorize patients into those that are at high risk of further disease or not. So, this is a useful way of knowing the rating of what BMI is to us today. So to drive home that point further, if you look at the bottom part of the slide, you can see that here if you go by BMI, somebody who's 28, 30, 36, or 36.2, these two are the same. But you can see the notes over here that one of them underdiagnoses obesity because body fat is excess, but signs and symptoms are not there. And this patient, according to the Caucasian guidelines, is just overweight. Whereas somebody who has obesity but no excess body fat, no signs and symptoms, then obesity can be actually overdiagnosed, and that will bring us to beyond BMI. and so on and so forth. So two people with the same 36.2, but one has got obesity with preserved health because there are no signs and symptoms, and there is one who has got obesity with ongoing illness because there are signs and symptoms. So you can see here that if you go only by the BMI, you're either going to overdiagnose, underdiagnose, or you are not going to identify people who have risk or no risk. And that brings us to the heterogeneity of obesity. And this is the main reason why BMI is insufficient in categorizing obesity types, because obesity itself is so heterogeneous. You have genetic factors, you have nutrient regulation, there's neural control, there are different adipose tissue types where you have white excess of white or brown or beige, and they all have different metabolic properties, and fat cell size and number also influence metabolic health. And therefore, to understand all these diverse mechanisms, it is crucial for developing personalized approaches. And that's why BMI as a one size fits all cannot be used as a sole means of defining obesity. So there are better measures of body composition, not just weight. So to put it in a nutshell, we look at waist circumference. It was very beautifully elucidated by Dr. Anup Mishra about how waist circumference is useful, but also how difficult it is. There can be he told us about how different it can be because very subjective, but it shows that it is a stronger predictor of health risks than BMI. And for a given waist measurement, health risks are similar regardless of whether someone is classified as normal weight or obese by BMI standards. There are other indices. Waist to hip ratio is inaccurate, as was already told in the previous lecture, and waist to height ratio may offer better insights, but simple waist circumference still remains a practical clinical measure if you had to look at something beyond BMI. There are advanced measurement technologies if you want to go beyond, when you want to go beyond BMI. So you have BIA, that is bioelectric impedance analysis. You have DEXA, you have MRI, you can go for CT scan, and there is something also called 3D optical scanning, which is emerging. So all of these are there, which can give you better guidelines about body composition when you go beyond just the body mass index, that is just a number on the scale. So let's look at it in a holistic fashion. This is from the European Society of Cardiology, where they have said body mass index versus body composition measurements. Let's look at the pros and cons. I already told you about the pros and cons of body mass index, wherein the cons are that you don't know the fat topography, where it is, you can't measure it quantitatively, so you can't measure the muscle mass and so on and so forth. The pros are that it is very, very easy and it can correlate to a large extent with waist circumference. So those are the pros and cons of body mass index. When you go to body composition, the pros, of course, whether it's MRI, DEXA, or BIA, we know that you have reproducible results in body composition, and you know where the fat is located, how much of fat is there. So quantitative measurements you can get. And BIA and DEXA is not so cheap, but BIA is cheaper and affordable, widely available in many different settings. But the cons are that accuracy varies among different imaging techniques. Like if you were to do BIA and CT, they would be widely different. DEXA and CT, you do get radiation. CT and MRI is more expensive, time consuming, not widely available. BIA is good, but you need a very good machine because it's highly sensitive, because it subtracts the liquid. So you have to have a proper hydration status. It's highly sensitive to that, and it requires consistency in measurement conditions. For example, early in the morning, with at least maybe like 4 or 5 hours of fasting, so those kind of caveats are there. Menstrual cycle in women can affect the hydration status and so on and so forth. So there is variation across various devices and algorithms. And DEXA cannot provide volumes, and it can't estimate muscle fat infiltration, less accurate for extremely obese individuals. And that is why there are pros and cons. So can you throw anyone out of the window? You can't. So you need a combination of all of these. So this is how you have the pros and cons of going beyond BMI also. This was shown to you, Edmonton obesity staging system, way back in 2009 when it first came. It was accepted very quickly by all the international bodies because for the first time there was a staging tool that went beyond BMI. So they looked at other staging methods beyond BMI, such as the metabolic status. They looked at the mental status, and they looked at mechanical issues, all of which are either associated with or consequences of obesity, and they all affect the risk status. They change the way the patient is managed. It prioritizes patients that require management early versus those that can actually wait. However, as was pointed out by Dr. Mishra, it may be difficult to do this in the Indian setting outside of dedicated centers because it requires a lot of data, a lot of investigations, and a lot of protocols. And though it is in an ideal world, yes, it's a good staging tool, but may be difficult to implement on a large population basis. So this was the first one that came in. Then all of us know about the Lancet Obesity Commission that came out this year, and that talked about just two stages. This is again going beyond BMI, preclinical and clinical obesity. Simple thing is BMI is done in every patient, but you do something additional such as a waist circumference. There are options. So it doesn't tell you that you have to take this option or that. You can do waist circumference, you can do BIA. You just basically try to look beyond the BMI and go to body composition. You look at clinical manifestations, either they're there or just mild, or they're there in a big way, limiting daily activities, and also there could be complications affecting different organs. So basically, the detection and diagnosis encompassed anthropometry, which is BMI and beyond, and medical history, review of all the organ systems, and further diagnostic assessment. So it's not much different from the Edmonton obesity staging system. However, it has been made simpler and just divided into preclinical and clinical. It is easier because it is a kind of, no, I wouldn't say vague, but it is simpler, and there are not too many facets to be looked into, not too many tests to be done. So a lot of it is based on history and simple tests that one otherwise also does. So this is basically how you define, according to the Lancet Obesity Commission, preclinical and clinical. So those people who are classified as having preclinical obesity, they have no organ or tissue damage. Their day-to-day activities are unhindered. They are at high risk of developing diseases in the future, metabolic diseases in the future, including cancers. However, the next stage, that is clinical obesity, is one that is a chronic disease due to obesity alone and characterized by signs and symptoms of organ dysfunction. There is a hindrance to daily activities in some form or the other. So, here also, if you, for example, now, if you had to look at someone whose daily activities are reduced, you would naturally ask the question why. The question why could be because of obstructive sleep apnea, or because of osteoarthritis of the knees, or urinary incontinence. These are the same factors that are factored in even in the Edmonton obesity staging system, but classified under mental, mechanical, metabolic, etc. So you're asking much the same questions, but just putting them in different buckets, so to speak. Now, with all of this, what are you aiming to do? With all of these, whether it's the Lancet or whether it is the EOSS, what you're hoping to do is you're trying to get metabolic phenotypes beyond a simple classification of just body mass index. So when you go beyond body mass index, you are actually going to metabolic phenotypes. So you get the normal weight obesity. As the name suggests, these are individuals with normal BMI but excess body fat, and they often have metabolic abnormalities. Then you have the metabolically obese but normal weight. So BMI wise, they are normal, but they are metabolically obese because they have metabolic abnormalities associated with obesity. Then you have the metabolically healthy obesity, which is in direct contradistinction to the second type, where these are obese individuals. They don't have any metabolic abnormalities as an index case seen at the time that you are seeing them, but they may develop these complications over time. So, to me, that is actually a misnomer, because metabolically healthy obesity may not stay as such. It is probably something in transition. And then you have, of course, the metabolically unhealthy obesity. These are people who are obese, BMI wise, and they also have metabolic abnormalities. This is the highest risk group. So, this is how you have phenotypes when you go beyond the BMI. This is an extremely interesting article which I urge all of you to read, where they have done this kind of a phenotypic classification. So here you have normal weight, you have overweight, and you have obesity. So on this axis you have the BMI, and then you have two categories, healthy and unhealthy. So you could be any one of those same six phenotypes that I talked to you about. So when you divide them, you can divide them BMI wise, and then just classify them as healthy or unhealthy. And how do you do this? You can do it simply with just waist circumference. Body mass index is something you would have already done, and you do a waist circumference. Of course, you should replace this with Indian values. And then you can also look at waist height ratio, because we said that waist hip ratio is not really very useful. So you look at waist height ratio, and the cutoff point is 0.5, whether it's men or women, and normal is less than 0.5, and increased risk is more than 0 or equal to 0.5. Very simple. So you could use whatever suits you. If you have someone who can do the waist circumference very nicely, you can use only the waist circumference. You want to go a little beyond that, you can do the waist height ratio as well to classify it further, so you get a better idea of the risks that the patient is facing. And these same authors then have this nice phenotyping system, where this is one is for men and one is for women, and you find that they have color coded these people based on waist circumference and body fat percentage. So you can have body fat percentage, which you can do even by BIA, and you do the waist circumference, and then you actually put them, the 1A on both of them. This is women and this is men. If it's green, it means you really have no risk. And then as you go to orange and as you go to red, the risks start to increase. That means as the body fat percentage increases, as the waist circumference increases, you get into worse categories, worse in terms of risk. So this is a very nice way of actually putting it down. Essentially, they all say the same thing. You're talking about fat percentages, you're talking about waist circumferences, and you are predicting risk. So this is the seminal paper that came out under Dr. Anup Mishra's leadership. I was proud to be part of this India Obesity Commission list, and everybody who's on this webinar has been on this obesity commission, and we're all very proud to be part of that. So this is the revised definition of obesity in India. I'm not going to speak too much about this because it's already been spoken about. This is the only slide I put up over there for that. So you have stage 1 and stage 2. It is a little in contradistinction. It's almost the same like preclinical and clinical of the Lancet Obesity Commission. But here we have a BMI of 23 as the cutoff. And for stage 1, you need to have BMI as mandatory. Body composition is optional, that is waist circumference, etc. But the patient should have no symptoms, no disease. Stage 2 is BMI more than 23, but there should be at least one additional measure beyond BMI, which could be waist circumference or waist to height ratio or body fat. You could use the BIA. And along with this, there should either be signs and symptoms, or there could be disease. So that is a very simple thing to do, and you just classify them into stage 1 and stage 2, and you know who needs treatment. This is from various studies put together, Indian cutoffs for other obesity indicators beyond body mass index. So waist circumference, we know 90 and 80. Waist hip ratio, we know 0.9 and 0.8. Wrist circumference, I'm going to show you some data about that, not really for adults. Neck circumference is another one. We do not have enough data for all this. This is for exploration. Body fat percentage for it's 25% and 30% for men and women respectively. And body mass index we all know. So body fat percentage is something we don't have robust data to tell us what the cutoff should be, but these seem to be reasonable cutoffs based on various studies. So as I said, these are alternative obesity assessment. However, wrist circumference, we have some data, but the data is good only for overweight children and adolescents, not for adults. Neck circumference, it is around 35.5 in men and 32 centimeters in women. That indicates obesity measured around the neck at the level of the most prominent portion of the thyroid cartilage. So we have some data for that. Not so if you want to really go beyond BMI, study it, research it further. These are some of the tools. And of course, body fat percentage that I already alluded to. So to conclude, you need to choose the right assessment tool. There is no single perfect measure so that can accurately measure everything. So you must consider accessibility. BMI, yes. Waist circumference, yes. Waist to height ratio, these are rather simple. Advanced techniques, they may be more accurate, but they are not accessible. And you need to look at prevention strategies as well. So thank you all for patient hearing. I hope I've done justice and at least given a snapshot of how you can go beyond BMI and assess obesity. Thank you.
Yeah, thank you very much, Neeta. And it was a wonderful presentation. And actually, you have incorporated almost all the guidelines across, and most of the measures which have been proposed to be defining obesity or indicating bad versus good versus bad or whatever. Now, importantly here is about the neck circumference. Do we have any some data from Indian standards or you or Dr. Anup Mishra sir about the neck circumference? Because
No, we have not
Neeta.
Yeah,
had any
there's just
research on
there's
the
very
neck
little
setup.
data that I found. Yeah.
That's one thing which we research, what you rightly said, could be for
Yes.
our
Yes.
population. The population, I feel, and there is one Lancet Obesity Commission also seems to be quite simple, like what we have Dr. Anup Mishra's proposed criteria. Even that is easy to understand. So they are good things, but of course EOSSS seems to be little complicated and less likely to be followed by most of the clinicians at large. But good for the research purpose. Over to the topic. Both the speakers are here. We have our panel also. Do we have any questions or comment in the chat box, or someone has?
Can I ask a question, Dr. Sunil?
Please go ahead, Manoj.
So, no, I think both very, very interesting and enlightening questions. My question is to Neeta. Neeta, multiple aspects you showed of really diagnosing obesity. So, one aspect and perspective is being really more specific in today's times now that we have tools available.
Yeah.
As BMI may not be the best means of, and you showed why only BMI may not be. One aspect is, yes, we are getting more specific and trying to really diagnose what was getting missed out. But it also opens up the question that at a population level, does it cause more confusion even at the primary care level? Is this something which makes people then afraid to get into this because what seemed to be a simple measurement is now having too many options? That's one. And the second is, for those who may have the means, let's say of a, BIA machine, then how important is it at those centers to still look at the waist hip ratio and the waist circumference and do multiple readings, or the ones which have the tools and could just stick to one of these and move on?
Uh, yeah, it all depends upon how many people are working for you and how much time you have. So it's good to have everything, but waist circumference is extremely simple to do, but there's subjective bias. There are different people do it different ways, and the same person doing it twice also, you may not get the same thing. But it's something to go by, and at in a large portion of the BMI slice, it does correlate with fat. It does not correlate in some, so above 35 BMI, actually there is no sense in even doing the waist circumference. That is a well-known fact that beyond 35 BMI, you don't really need a waist circumference because you know it's going to be high. So the importance of waist circumference comes especially at lower BMIs. That's where we are missing those people who are at risk. So yes, at least one of these methods should be applied. And that is why if you see even in Dr. Anup Mishra's paper, you will find that there's an option. You can use any one of them. You can use waist circumference, you can use BI, you can use some method of trying to find out what the body composition is. I think it's a question of education. So, if we give only one more tool to the primary care physician of simple waist circumference, BI is not possible for everyone. And if we teach them the right method, I think that should be good.
Can I add to that?
Of course, sir.
See, Manoj, the only way you can truly define obesity is by body fat. And the only way you can do body fat is by complicated measures. Uh, BI is one, DEXA is another, and then plethysmography and things like that. Now, as far as BI is concerned, it is prone to errors and depends on which machine you're buying. There are machines which are for 2,000 to we have a machine of 15 lakh, uh, which is a high-end machine. So it all takes money, although it doesn't take too much of time, but it takes money each time patient has to pay. So if you want to do initially and every 6 months or so, it is a feasible thing for somebody who can pay. Uh, but if you are seeing patient every month, for example, on a GLP-1 receptor analog, you want to see patient every month, then a simple weight and waist circumference will do. And most of the studies, almost all the studies of GLP-1 receptor analogs are based on BMI. They're not based on body fat. So I think it all depends on what you have, what patient is comfortable with, what you are comfortable with, how much money is patient going to spend. But the best is the simplest. I believe in very simple measures, and simplest measures are still BMI, weight, and waist circumference.
Thank you, both of you.
Actually, we have a very elite panel. We have Dr. Bansi Sabu, who has recently worked on BMI, and along with Dr. Narwaria, a new criteria has been introduced. And Dr. Narwaria is our honorable president. And we have Dr. Makkar, who has been a obesity man in the country and the world for so many years. And we have, of course, Dr. Manoj, who has already started the panel. So they don't need much introduction, but I'll be happy to take up questions with them. So before we receive questions, I think the issues of BMI and the measurement has already been taken into discussion. And we have a question from Dr. Sudhir Jha asking regarding the treatment, the obesity management, especially in reference to GLP-1 receptor agonist. He wanted to know that what is going to change. So any of the panelists want to take it up, we can take before the other questions come.
Before others respond, I just want to point out that
We can ask Dr. Braj Makkar to start.
yeah, the slide which I projected.
Sorry, sorry, yes, sir.
Stage 1 and stage 2 obesity will decide the treatment actually. And the stage 1 obesity, you go to the lifestyle measurement, and stage 2 obesity, you be aggressive. Only thing is that they present the limits of BMI for use of GLP-1 receptor analogs have been decided by the Drug Control of India, and so one might stick to it if one has to be ideal. Otherwise, like everything, and like bariatric surgery, where limits have been lowered, uh, stage 2 obesity, if it's present and patient has atherosclerotic cardiovascular disease, you may start GLP-1 at a lower BMI. So be aggressive in stage 2 obesity, but it depends on the profile of the patient, how aggressive and which type of drug that you will use.
I think in the era,
Uh, Okay, so can we ask that question to Dr. Makkar about the GLP-1 analog?
I think Dr. Mishra very rightly pointed out. First
How
thing
the
is,
new
am I audible?
yes, yes.
yes, you are. Yes.
So I think Dr. Mishra, very rightly pointed out. First thing is, now the revised cutoffs when to start treatment. That is the first thing. Second thing is we have to be aggressive in obesity management if we want to prevent so many diseases that are associated with obesity or the comorbidities or the complications that arise out of obesity. Also, when we are using GLP-1s, the criteria, if we look at the previous publication where I was fortunate to be with Dr. Mishra in 2009, the definition was very clear that if you have BMI more than 25 plus one comorbidity or no comorbidity and more than 27.5, these are the patients who are candidates to be considered for pharmacotherapy in conjunction with lifestyle interventions, though there were no GLP-1 receptor agonists that time. And I think the same criteria holds true even now, but it is more simplified with the current definition that it is not just BMI, look at the clinical profile. And if you have clinical indications, I think there is a good reason why you should consider GLP-1 receptor agonists or other obesity management medicines or AOMs, whatever you want to call them. Also, I think it is very important for a person sitting in the periphery, as Dr. Mishra mentioned, to understand how to diagnose obesity or clinical obesity and when to initiate treatment. And that is where these kind of guidelines are important, where we have to have very, very simple statements or guidelines which are able to guide a person sitting in primary care on how to proceed with the management.
Dr. Narvaria, you're saying something and you're supposed to ask something. I feel you raised your hand and for Dr. Anup Mishra,
Yes.
some question you had. Yeah. Dr.
Yeah.
Yes,
Narvaria.
please come in.
Yeah. First of all, I want to thank both of speakers who've done a wonderful job. I think the topics were so nicely covered and they uh, update us on the new definition of obesity. And we are very happy. For me as a surgeon, I learned a lot. So thank you so much for bringing this topic for the discussion. About this GLP-1 era, I think we should have some or other tool to measure their body fat percentage when we are starting GLP-1 therapy, because it should be monitored, it should be supervised, and it should be as taken care uh, taken very seriously. Should not be prescribed like any medication which is just prescribed, people keep taking it just like insulin or diabetic medications. So I think muscle loss and fat percentage change may alter their future complications if they stop the medications.
I think this is a very important point. I thought I will discuss this, but then I thought let me restrict to the diagnosis and the guidelines that we have been discussing. But I think people are going totally haywire as far as the adoption of GLP-1 RA therapy is there, and people are coming to clinics and asking, sir, can you give me Manjaro or can you give me Vigovi? Not asking for that I want to be treated for obesity. They just want to get the injection done. And I've come to know some of the people, are getting it done through gym trainers or even the, beauty clinics. These beauty clinics are also giving you GLP-1 RAs. And with, simple body composition analysis using a BIA, which is not very expensive, at least you can get an idea of what kind of, weight loss they are having. Because they give you some differentiation between the lean mass and muscle mass, even if the fat mass, even if it is not accurate. And if you are doing serial measurements on the same machine, you can actually, have some documentation that what is happening. And I think it is very important that everybody should understand if you are using GLP-1 RAs or maybe, something like tirzepatide, though these drugs are very potent in inducing weight loss, weight, but it is very important to advise a regular exercise to every patient who is going for weight management therapy. And we had very clear-cut recommendation. In fact, the 2009 paper was the first paper where the recommendation came that 30 minutes is not good enough for Indian population. We should look at 60 minutes of activity with at least 15 minutes of strength training on alternate days for all the people living in India. Am I correct, sir?
Absolutely. So you have rightly said that those people who are asking for GLP-1 receptor analog these days actually are the people who don't want to exercise, and
Yes.
their diet will be suppressed because of GLP-1, but exercise they don't want. And this is what needs to be emphasized, because most of the people who are like that, their muscle mass will be lower, and they may lose fat and they may lose some amount of muscle. There is a relative malnutrition type of situation which is induced in such people, and unless they do resistance exercise, have increased protein in the diet, they are they're going to be worse off as far as muscles are concerned. I don't know whether it'll be worse off as far as bones are concerned. Nobody has shown us that. So this is something which needs to be taken care of, and adequate instructions need to be given. So initiating a GLP-1 receptor analog needs a lot of counseling and a lot of instructions, diet and exercise, everything right in the first go. And then only the patient may understand, may do it, may be better off.
Sir, I have a
Very well
question.
said, sir.
Can
Sir, if I can
Purvi?
just, yes,
Acha,
sir.
okay, go ahead.
I just want to take one point from what sir has said. Sir, so very truly said, and Dr. Makar sir also very nicely you have described what is actually happening today in practice, because patients are themselves just coming forward and saying, write this for us, prescribe this. And if we don't do that, they'll change the doctor, which is perfectly okay. We don't have to compromise on scientific standards. However, what about say, a special subgroup, say women in the perimenopausal period, where it is inherently very, very difficult to lose weight despite multiple efforts at, optimizing diet or even including regular exercise with strength training. And we do tell them that you just stay focused on that and there will be results. It may be slower than the remaining population, but it will be on course. Any comments on that particular population and the role of GLP-1 receptor agonists for them?
There are subgroups, Purvi, where the weight loss will be difficult even with the most potent of the GLP-1 receptor analogue. One is the women, which you have rightly put in the perimenopausal and menopausal stage, and that's one subgroup. The other groups are people who are already on multiple injections of high dose of insulin. They will have a difficulty in losing weight. Diabetic itself will have a lesser weight loss than the non-diabetic people.
Yes.
And for some other reason, there are a group of 5% of the people who will not lose weight even with this, or have suboptimal weight loss. Now, recently, just 2 days back, uh, a genetic polymorphism, neuro-BCM gene has been found, and those who are not responding, there's a high propensity of that polymorphism. So something like that will be found. There'll be a gene-drug interaction also in some of these people. But fortunately, with the potent drugs, the those non-responders are less than 10%, or maybe less than 5%. So that, and these are the categories that you rightly pointed out, where there we have to tell them that the all the more important to do more exercise, and diet has to be proper, and they have to follow a diet chart, and plus the drug. Now remember that GLP-1 analog, um, the Monjaro or Wegovy, they decrease appetite in many people, but that is not 100%. That is not 100%. So The appetite in these studies, which have been around 20%, 25%. So it's not a universal decrease in the appetite. And some people will lose appetite in the beginning, and then they are fine with the appetite. So actually, food reduction because of the drug is something we should not rely on. We should give them a proper diet chart and decrease in the calories, etc., whatever you want to do, in addition to the GLP-1 analog. So don't rely on that. They themselves will decrease the calories.
Also, Purvi, perimenopausal women, they have, very strong impact of the hormonal changes, which leads to very high degree of insulin resistance in them. And there is a lot of impact on mental health also during that phase. They are, no, it is not just the weight gain, it is important. They have so much of emotional turmoils and insulin resistance. And in fact, 2 days back only, there was a paper which looked at women who were on hormone replacement therapy and were given GLP-1 RA. And their weight loss was significantly better than those who were not on HRT. So I think you will have to see individualize the case approach. And if somebody is not responding and has very strong menopausal features, maybe you will have to combine with HRT in these patients.
Sure, I think that makes perfect sense because anyway, we want to ensure that even cardiovascular disease is, sort of prevented in them.
Yes.
Any data regarding the experience, Indian experience, or this tirzepatide or semaglutide in our country and in the Western population, the way the whole world has experienced is
Dr.
India
Panda,
going.
it is only 3 months that we have started, officially using these molecules.
Yeah,
There
So
will
the
be some real world data will be
experience,
produced maybe in another few months.
only experience I can tell you is that you can expect unexpected side effects and you can expect non-responders.
yeah, exactly.
I have a patient who is on, in one of the injectables. And every time the injection is done, the person starts getting headache for next 3 days. And then the headache subsides. And you give a repeat injection, then headache comes and it stays for next 3 days. And we have put a CGM on him, to see whether the hypoglycemia is happening. No hypoglycemia. Glucose is always in the range of 90 to 130, 140. But headache comes and it stays there for almost 3 days. So, you start seeing new side effects. The first patient I put on Manjaro, a physician, lady physician, had profuse diarrhea, which lasted for 5 days. She had to be hospitalized for rehydration, you know.
Yeah.
So you never know what you come across in your patient pool. So it is, I think, too early to
Yeah,
give
yeah, tell.
a
So it
generalized
is
opinion.
So at the ADA this year, we presented the first real world experience from on tirzepatide from India. Uh, it was a dual digit number, more than 50 patients, and 6 months use. But I would say that, and the results were fantastic. But let's say that because they were procuring tirzepatide from not from India and from outside, it was at a very high cost. That cohort is enriched. We did see fantastic results, and the tolerability was also very, very good. Of course, the usual side effects were experienced, but they are very manageable. But despite of that, they have lost, double-digit numbers, more than 10 kilos.
The
So they've
weight loss
done
is fine, but you are seeing, varied side effects even now. And I have two
exactly,
patients
but this
already
we
who are
already
totally
had six
non-responders.
months experience with tirzepatide outside the trials,
Yeah.
and this was from Dr. Banshi sir, Manoj, and myself, and we presented this in a poster at ADA this year itself. But I would still call it that it's not going to be the same that we see now because this was an enriched population. Obviously, those who were not responding did not want to continue with this expensive therapy. So they had
So
discontinued.
we have, in
Those
our
who had been
practice, we have two
responding.
patients. we
just
have
want
two
to make
patients.
one
Just
more.
Bansi, just give me 1 minute. In our practice, we have two patients. With the Munjaro being in vial and single injection, we have the advantage of rapid titration also.
Correct.
Both these patients did not have any impact with 2.5. So first week, second week, they said, sir, this drug is useless. So I said, fine, we'll give you
So
5 milligrams.
share
In two weeks only,
Dr.
we
Dr.
put them to
Makkar
5.
say.
Just Sunil.
Hmm.
Third week, again, no impact. So we made it 7.5. In 4 weeks' time, they were on 10 milligrams. No impact. Zero. Finally, we had to stop. Totally non-responders.
No, sir, we've gone all the way to 15 milligrams, and the results
Yeah.
have been astounding. They
Yeah.
have been fantastic. More
No,
than
no, this is
2
generally
someone on
they are good.
insulin. Agreed.
Generally, they are
But
good, but
there is
there are
a
non-responders
heterogeneity in the
also.
response. Absolutely agree. There
Banshi
have
wants to
been
say
enough
something.
non-responders.
Yeah,
Banshi?
Dr. Sunil and Dr. Bansi. Yeah,
So
yeah.
I just want to make some comment one and to experts like Anup Mishra. There are two varieties of patient. One is who had come to us for diabetes. And we know that there are many diabetic patients have multiple cardiovascular risk factor. They have obesity. The first choice of therapy for us is GLP-1 to use for these patients. And we want to explain them patient for the GLP-1 process. And if they develop side effects, then that's again a challenge for us to continue for that because patient was not primarily prepared for it. And if we talk to them that this molecule is going to give you a lot of help for reducing your weight, and that is what our aim is because it will help to reduce your cardiovascular risk also. But there are patients who have come for obesity management. They have primarily come for the idea that they had come to you for managing their obesity or weight management, even they may be diabetic or non-diabetic. Then, to convince these patients become much easier, while the other sides of patients where they have come primarily for their sugar management. And when you try to say that this is a molecule which is not only going to give you good control of sugar, but at the same time, there will be weight also will reduce and we will have so many benefits, plus, plus, plus. And we try to explain so many things about the obesity and then try to convince. Well, now most of your diabetic patients, the first choice of therapy is GLP-1 and SGLT2 because that's what they have already the multiple risk factors. And then it becomes extremely difficult if they develop side effects. Either they develop side effects or they don't respond. But mostly I have seen even they are not reducing the weight, they respond in good sugar management. I mean, the sugar is very, very good control. So, in some patients, you may find that weight reduction is not very, expected like you are expecting in 2.5 or 5 milligram after 3 weeks, 4 weeks, or 6 weeks. They should reduce this much weight loss, but still they responded very well as far as the sugar is controlled. That's very, very good. So, that's my personal experience. But again, there are non-responder. Maybe reason is the cost. Maybe their expectation is very high. Maybe their side effects, diarrhea, headache. These are all side effects which we have seen. Because if you had used in 2 digit, if you have used patients more than 50, maybe different molecule. One thing which I have seen is in compared to semaglutide, when we want to increase the semaglutide dose more, they develop more problem in compared to tirzepatide. Comparatively, the side effect profile is less. I mean, the GIP addition is really giving the benefit to them. I mean, here we are not trying to comment only for one particular molecule, but this is, I think, internal discussion where we can say that we found better response in comparison.
Yeah, Dr. Sunil.
And even they are not for appetite suppressant is also even less, but still they reduce the weight. Yes, Dr. Sunil. Sorry.
Yeah, this is again just to share with you to one patients who are on tirzepatide now, and Wegovy started recently. So one patient has the same history what Dr. B. Manjaro here. It's a 1 week I got multiple diarrhea episodes. I said, you stop your medication, don't take the second dose. But this is there. But other 24 patients, no one has called me up. They are well tolerating. That's one thing. Second is about SEMA versus of the semaglutide and rather CagriSema. So we certainly have found that the side effect profile seem to be less in tirzepatide versus others. But some of our colleagues said that the weight reduction is not so often. The three doctors, we had one meeting, three.
Really, your voice is dropping. I don't know.
The connection is poor actually.
Yeah.
Sunil, I think
Really?
disconnected.
No side effects, and they're taking almost since 2 months. So that way, for next 72 hours, there will be less appetite. After 72 hours, means the fourth or fifth day, the appetite becomes gradually normal. And they said that's why we take medicine on Monday, so that Monday, Tuesday, Wednesday, they have less appetite. But then Thursday, Friday, Saturday, they can, Friday, Saturday, they practically go for the feast. They said, we wait for it. So these are some important clinical clues that the adverse events or the side effects are much more when you take injection first 3 to 4 days versus other days.
Now we have a quick question from the chat box. There is a question from Dr. Anil. He asks that if there is a raising waist circumference, but triglyceride is not raising. So waist circumference has increased, but triglyceride remains normal. Is there any significance? Maybe some clinical correlation he is making. So any of the panel want to put any comment on this?
Most of the time, the increasing waist circumference will correlate with the triglyceride. And in fact, long time back, from Canadian people, this was
Hypertriglyceridemic waste
yeah
was what they had.
hypertriglyceridemic
Yeah.
waste. So this was a phenotype, hypertriglyceridemic waste. But if suppose somebody's liver is not dysfunctional and he or she has abdominal fat, uh, then triglyceride may not be impacted so much. But on the other hand, within the same waist circumference is not increased, but the liver size has increased, and it is 20, 21 centimeter with the fat which is on fibroscan 350 or 390 or something. Clearly triglyceride will increase and HDL will decrease. So that is the function of more of a liver. Then the some function, of course, will be intra-abdominal subcutaneous fat, but liver will be more.
So
Great.
I think,
So I
yeah.
think can we move on with the remaining questions, because we are coming to the close of the webinar. So I would quickly like to go through the panel with some questions.
Yeah.
So I think Dr. Banshi sir, if you can give us a quick pointer on what is lacking today in the obesity management guidelines, if you feel that anything is indeed lacking, because it was very well covered that we do probably need the guidelines, and we have the guidelines for Southeast Asia, including India. So I'm just moving on to if there are
So,
any
Purvi,
gaps.
if you see this year in ADA, there was a session on guidelines. In the first session is that, guidelines we are making since last 25 years, and diabetes guideline which they are reviewing and revising every year. But still they feel that American physicians are not using in their clinical practice. So it's what it is not used. And this is what US, where everything is reimbursed and they have to justify whatever they are prescribing. And even it is written in the guidelines. So you see in India, where the guidelines are already there, whether the primary care physician is using or not. Now, obesity is one very challenging issue in our country. Diabetes is still established since last 30, 40 years. Primary care physician is also treating diabetes. They try to read the guidelines and they want to use it. But even the obesity guideline is there. How many of us are really using it in our clinical practice? In day to day, each and every patient, are we talking to them that whether they have some established cardiovascular disease or not, whether they have diabetes or other comorbidities, and each and every patient are we treating as per the guideline? But I don't see that any gap is there. But yes, definitely it has to have some regional impact. So for that, we should have our own guideline, maybe from Southeast Asia, maybe from our AARO. Even though the international guideline might have talked about the South Asian, they know that we are different, we are lean, we have comparatively more visceral fat. Our BMI is not more important in compared to that. Our visceral fat percentage is more important. But whenever a guideline comes from any society, which may be from like Indian society, if we come out, then more Indian physicians or more Indian doctors will have more faith in it. And we can always compare it with the Western guideline or international guideline. But I don't find any at present there is a gap, but I find more gap is it is not practiced anywhere. The guidelines are every year being produced, but it is not practiced by the primary care physician, and even sometimes even not by the experts also.
I think Dr. Anup
would you
Misra
agree?
wanted to leave. Let us say thanks to him. Dr. Misra want to leave. Purvi.
Sir,
Thank you.
if you want to make the comment on the same, so that
Yeah, I just appreciate you people arranging this particular seminar. That is my final message. And Purvi and Sunil and Jayant and Dr. Narwaria, I'm very thankful to you. And it was great to listen to Nita and seeing her after quite some time and seeing
she
Banshi
reduced
after a
lots.
long time. And
She
always
reduced
a
lots.
pleasure to listen to Banshi. And of course, Manoj is always there supporting us. So thank you all for giving me this
It was a great time,
opportunity.
sir. It was a great
Thank
time
you.
listening
you
to
so
you
much.
all, and you have left a very important message to all our listeners. And Arrow is very thankful. You are, of course, our patron, our Gurudev, our Bhishma Pitamaha, but we are very thankful for making this time in the evening for all our attendees for a very important purpose. Thank you, sir.
Thank you.
Really
Thank you, sir.
appreciate it, sir. Thank you so much for
Thank you,
being
Purvi.
here.
Thank you.
Sir. Thank you very much, sir.
Okay,
So
so
now we can continue relaxedly.
okay, so the
Continue with
webinar
the
is still on,
again for
sir.
another 10,
So I
15
have a
minutes.
quick
It's on.
question.
But for the
So
guideline, I just want the comment. Actually, I asked Dr.
Recording
Anupchand that what
stopped.
is his comment also.
surgery, and what is your suggestion? What are the literal points that you would focus on for these patients?
So Purvi, one is the procedure which they do and at what BMI we are operating and what age. So there are multiple factors which are responsible for a outcome of peribariatric surgery. So if we are doing a sleeve gastrectomy after 50 BMI, they may not reach their target and they're still having a low BMR and they may start regaining weight. And as such, the sleeve will increase in size within 2 to 3 years and they start eating more and they will start getting. Another problem with these patients, they develop reactive hypoglycemia. So they develop a kind of craving for high carbs. They start eating high carb. They enjoy eating chocolate, ice creams, and all, and they don't come to doctor. They think it is normal, but actually, if they come to doctor, we can control this hypoglycemia, and we can treat this, and we can still continue losing weight, and we can even maintain. And definitely, adding few medicines like carbos or metformin will also help reducing their craving and maintaining their weight. So I think simple medicine can help them.
Great. Thank you, sir. So that establishes the role of anti-obesity medicines even with bariatric surgery, and that's an important takeaway. And it's of course team management, because we may need to there should be a physician on board also to manage these patients post the surgery, and a nutritionist as well as an exercise physiologist as well on the team. So thank you for that.
Compliance is a major issue. In our country, people don't want to go back to doctor for even regular follow-up. So follow-up, those who are when lost to follow-up, they'll gain weight faster and they'll come back with for the revision surgery. So I think the regular follow-up, we always write down in our discharge summary, these are your follow-up dates. You have to come and see us. And we tell them that if you don't follow us on time, you may not reach your target and you may start regaining weight. And yes, of course, the team approach is very, very important. So we add the medicine whenever there is a nadir of their weight loss, we add the medicine and start losing. So we need to break the plateau and to reach the target. And whenever they start regaining, we should again enter at that stage, adding medicines to control and reduce their weight.
Sure. And for that, I would like to ask Dr. Manoj one thing about these anti-obesity medications. Is monitoring important along with that? I mean, and I'm particularly referring to blood glucose monitoring also. And besides that, I will then rope in Dr. Sunil Gupta sir and Dr. Neeta for their comments on the other monitoring that we should include.
Okay, thanks, Purvi, for that, and thanks for having me here in amongst the IRO board. Yes, I think we've been talking about this aspect, the need for monitoring when you're using these new incretin mimetic drugs, also referred to as anti-obesity medications in the current times. Two things I would say particularly, and again in the questions in this symposium, it's already been discussed. So one aspect is monitoring the aspects of body composition analysis. So whether you're using the BI and keeping a tab on the body percentage fat, the skeletal muscle mass, the extracellular water, and we understand today to ensure that patient continues to have benefits, and what you want them to do is lose their body percentage fat and not the muscle aspects of talking to them, conversing with them on training, exercise, resistance training, and protein supplementation is extremely important. And I think that's where patients who are taking these drugs under supervision from any of the a set of doctors here tend to do better than what happened in the past, and what we started hearing reports when people were using it more off label, and you started hearing about the Ozempic face and Ozempic butt and all those aspects, was because it was unsupervised and without any guidance. Also, interestingly, in the small series that we have at our center, and as you mentioned, we've been using it for over a year now. We did have significant number of patients who were taking it from the other markets, and now in the last 4 months, 3.5, 4 months in the Indian market, it's not necessary that we are seeing in everybody that there is a drop in muscle mass. So people who are doing reasonably good resistance training and doing protein supplement, to our surprise, in some of them we've seen good percentage fat loss, but the skeletal muscle actually increasing by 1 or 2, 1.5 kgs and things like that. So it's extremely good to monitor that. The second aspect is doing CGM. Again, we heard conversations. Dr. Makkar was speaking about a case which is having headache, and they did CGM. Especially in patients with diabetes, when you start using this drug, the ones who've been on other OHAs and insulin, the rule of the thumb is reduce your insulin dosage by 25% when you are starting these drugs. And keep a watch, because many of them may require further reduction of insulin and reduction of drugs like sulfonylurea. A small percentage may land up getting off most of these other drugs, and hence monitoring is extremely important. Other important learning point for all of us where we do CGMs is for patients who are non-diabetic and those who really do well. You will see a lot of sugar values which are between 60 to 70 on CGM. And those values between 60 to 70 on CGM may not always be hypoglycemia. So let's understand, level 1 TBR on CGM is not always clinically significant hypoglycemia. So people are getting a little worried and afraid because they are seeing the red zones on CGM when they are using the higher dose of semaglutides and tirzepatides. They are feeling absolutely fine. They are happy with their weight loss. So there is some amount of de-learning and learning that the physicians need, and hence this monitoring, that do not react to those as long as the patient is asymptomatic. Level 1 TBR may not be important to reduce your these drugs. Of course, if the patient is on insulin, sulfonylureas, or other drugs, you may want to keep reducing them and maybe knock them off where required. So these are two important aspects of monitoring that I'm focusing on. Would love to listen to any other specific monitoring aspects that anybody else is doing.
Dr. Sunil Gupta sir, Dr. Jayant Panda sir, we have Dr. Neeta, please, if you can add further on what Dr. Banshi is also here.
Yeah, monitoring when on the AOMs is what you're asking, right?
That's right.
Yeah, so I have been increasingly trying to be safe, and I've been doing amylase and lipase at baseline. And I have been checking it again, especially with the GLP-1s. I've been checking it again once in 3 months as a routine, in fact.
So suppose, Nita, it is increased more than 3 times. What will you do?
No,
It's asymptomatic increase.
I would definitely withdraw and watch, even if there are no symptoms.
So Nita, I just tell you because I have done
Some
some
amount
of
of
the
increase
clinical
going to be there.
trials.
Some amount of
I'm
increase is
sure
going to be
Manoj must have seen also
there.
that in some of
Absolutely.
the clinical trials, they have tried to see that if it increased more than 3 times asymptomatic increase, and then they were trying to do it 5 times and 6 times. And now we have designed for one Indian company also. And then we had seen even some of the patients who are given GLP-1. And if you just see their lipase level is 500, 450. We have done even their CT and sonography also. It is in clinical trials. It's not like the patient any have problem. And then we continued these patients. And there's no further increase. I mean, between lipase level of 300 to 500, I have many patients who have been used in clinical trials and there's no further increase. So I can
Yeah,
tell you,
what
Nita, that
happens?
I mean, if you just take your lipase and amylase level, not amylase, lipase level you will find in your 75% of the patient
It's
That's
raised.
will
true. That
increase,
will
and it
will
may
be
increase not 3 times, 5 times, 6 times, 7 times. And sometimes this I have seen even with DPP4 also. I have seen with Trulicity also. I have seen with all other older GLP-1. And in a different clinical trials, because in last 10, 15 years, all these GLP-1 had come and we had done clinical trials for all those, almost all of these molecules. This is my preselection. Manoj have done also a lot of
So,
clinical trials. What's your?
absolutely agree there. And so, as Neeta said, she would be cautious and knock it
yeah.
off. But
I would
asymptomatic
for
rise,
another reason, Manoj, because in a clinical trial, the follow-ups are very stringent, and we know the patient is coming back. But when outside of a clinical trial, when you're not too sure the patient is going to come back in time, and then they call and say that something has happened, and they're doing that also. That I've got diarrhea, I've got pain abdomen. You start panicking, right?
So
no, so
But
we
clearly, I
Nita,
think
more
there is a
very
panicking
lot
is
of.
for
important.
the investigator. I tell you, as a clinical trial, when you have to take the consent for getting all these investigation and to show the patient that this is your
So,
report,
I'll,
I tell you, and then you are worried of that this patient will go because
right,
cardiovascular outcome trial mean you have to follow
true.
this patient for
So, Vanchi,
3 years.
3 to
I
4
tell you, it is a
years.
hell of
let me
job
draw parallels. I think
and how to justify that serum lipase increase in that patient is very difficult because now this is not the patient. It means he's lost to the follow-up. If you are just withdraw the patient, it means this is gone.
so. My take on that is, you'll have to talk to those patients who are asymptomatic and let them be aware that in case they
Counseling
get the
does
symptom,
happen, no
but
doubt.
stopping it in all those patients may not be warranted. And the second aspect, as Neeta said, amylase lipase. Well, the literature would say that we should be monitoring calcitonin levels also, something that we did in the trials. But today, in the real world scenario, that's probably not practical. So, are we really monitoring calcitonin in all our patients on the IMDs? And I'm referring to continue to refer to these as the newer incretin mimetic drugs. Not so. I think a lot of things are idealistic and on paper, but when it starts using it in the scale that we are using it today, because the trials really did not show concern about that rise, and clearly there's a dictum that those with family history of medullary carcinoma, thyroid, which we
Exclude.
fortunately don't see here, we'll exclude them. There are certain things we are not monitoring, so which is fair. I think what Neeta is saying is something which is there in literature. It was the same like for glitazones that we had to monitor the liver enzymes when we all started using rosiglitazone 18, 20 years back. After a while, we never bothered. We never saw that. So similarly, this will evolve that if you don't have patients having these symptoms, we will not do it mandatory, but just the rise in these enzymes without any symptoms may not warrant discontinuation is an aspect to remember. I think Dr. Sunil Gupta
Yes,
wanted to say, yes, sir.
Yeah, yes, we have two of the clinical trials on this, and one of them is already over. That was 1.5 year. And out of this, unfortunately, then we came to know that all of our patients on were on the randomized on the drug rather than the control. All of them were selected, but none of the patient have shown 3 to 4 times rise in the amylase or lipase. So may not be so, and that's why. And of course, very rightly said, anything when it is more than 3 times rise, we should have to we have to warn the patient. We have to keep a watch and see the clinical, though it might be asymptomatic. But fortunately, in those patients, nothing was seen. Means there was no rise. There was marginal rise. It was observed, but not for 5 times, 6 times. Maybe Bansi, in our population, it was not seen so rampantly. Even in the current trial of CV outcome, which is almost 1.5 years now, I have not shown too much of concern about the enzymes.
No, but I'm not
Except
saying
the
every
side
patient,
effect,
but
which could
many
be
patients you will find. And we have seen many patients.
possible.
Only, and if you have
That's
the
what I'm
patient
saying. It's sharing this
gallstone,
part of the point.
Sunil, one more, if
Yes.
patient is having gallstone disease, I mean, then they have more chances.
Of having that,
Asymptomatic increase,
absolutely.
lipase and
Fully
Yeah,
agree. Fully agree.
gallstone pancreatitis. Gallstone
They are not
Pancreatitis.
pancreatitis, you can't say them because there is no inflammation, but they have amylase is, I mean, acute pancreatitis goes more with lipase, we are seeing more high.
Actually, they should be given importance clinically also when they are more than
One more,
1,000.
Manoj was very rightly said, कि how many times are we, as a check-in list, are we asking that आपके family में किसी को medullary thyroid carcinoma है? I mean, if we start talking about thyroid carcinoma, the patient 10 तरह के कार्सिनोमा बताएंगे और फिर कहेंगे सर उनका बुआ की बेटी का पता नहीं था और उनको भी किसी को हुआ होगा, लेकिन थायराइड की डिजीज, थायराइड डिजीज एवरी थर्ड पर्सन इज हैविंग, सो देन दे विल गोइंग टू से कि थायराइड है सब, फिर एक काम करो रहने ही दो ये दवाई काहे को लिखते हैं.
Yeah, very commonly it will
Even
be
that is true, but
misunderstood.
no.
Along
But then we
with
have to
GI symptoms of nausea, vomiting, and pain in abdomen, and if they end up going to a gastroenterologist, these drugs are completely stopped without even proper
They
monitoring of
stop even
follow-up.
metformin also.
Yes, they will stop
Very often.
metformin
First
also.
thing they
So
go
I
to stop
Diarrhea.
the metformin.
So I think, Purvi ma'am, it's almost 2 hours. So you have any
yes.
more questions or we'll wind up?
No, I think we have had a good
भूख
discussion.
लग रही है जैन.
Big
जैन को
round
भूख
of
लग रही है.
applause for Purvi, first of all.
Yeah,
Yeah.
yeah, yeah.
Arranging this
Our
wonderful talk and
So this
asking
was
Dr.
our
Anup
share
Mishra
of
for a keynote lecture, and then Nita Deshpande, we really enjoyed. The only thing, it started 7:30, so initial part I could not join continuously. Intermittently I was seeing patient, but wonderful. And under the
Sir,
leadership
this
of
was on behalf
Mahendra
of both of us.
and no,
We
under
were
the
supposed
leadership
to
of
arrange for this
Mahendra
webinar.
and Makkar Saab for this wonderful program. Sunil and Jen Panda has moderated very, very nicely. But I think these videos of these two talk we can also keep on our website, at least links, so if somebody wants to listen them more or second time.
Yeah. Very, very nice
Very
and
happy.
aptly
Nita,
discussed.
wonderful talk. अभी आप कहाँ चले गए? अंधेरा हो गया है.
नीता मैडम ने तो 10,000 स्टेप भी कर डाले चलते चलते.
Thank you so much, everyone.
Thank you all very much.
Thank you. Thank you.
Bye.
Good night,
Thank you.
sir.
Good night. Thank
for
you.
so
Thank you, everyone.
Good night. Good night. Good night,
amazingly
everyone.
sharing
Good
it.
night.
Thank you,
नंद
Banshi.
किशोर, मेरे को पता ही नहीं चला कि when you have done off and when you have done on.
Thank you so
चलो,
much.
bye,
night.
bye.
Thank you.
Bye.
And good night. Bye, good night. Good night.
महेंद्र भाई, कल मिलते हैं सुबह, एक्सरसाइज करनी है. चलो,
Recording
बाय
stopped.
मनोज.